So this work is part of a cross-national study. So we're doing the New Zealand arm of the study using the data from the integrated data infrastructure, and also collaborating with some colleagues who also use Norwegian register data as well to look at this. So before I move on, of course, those of you that work with the IDI will be familiar with the disclaimer. It's not official statistics, of course. Okay, so just in terms of some background, perinatal depression is defined as depression experienced during pregnancy and the first 12 months postpartum. Some studies define this more stringently as during pregnancy and 4 to 6 weeks postpartum, but others take a year-long postpartum definition, and that year-long postpartum definition is generally supported by those with lived experience and advocacy groups. So that's the definition that we've gone with here. Estimated prevalences can vary depending on region being looked at globally and the method used for diagnosis. But a meta-regression that was done in 2017 reported an adjusted pool prevalence of about 11.9%. This is similar to what we've seen in previous work in New Zealand as well. And risk factors for perinatal depression include stressful life events, lack of social support, relationship challenges, physical health conditions, including pregnancy challenges and complications, prior mental illness, as well as sleep disturbances. And outcomes associated with perinatal depression include adverse neonatal outcomes, so low birth weight and premature birth or lower gestational age, decreased breastfeeding initiation, and impacts on children's socio-emotional development as well. However, while there is research looking at impacts on the children in particular, there is limited evidence on long-term outcomes in this space, particularly specific to the mother themselves. How does experiencing this actually impact the woman who experiences perinatal depression? And of course, earlier studies in this area also focus more on postnatal depression as well, with more recognition now that symptoms can begin during the pregnancy period itself. So in some of the work, there have been calls in terms of addressing this to increase screening for perinatal depression in mothers. However, screening itself isn't enough. We also need greater availability and access to services. And to inform that need, of course, we need to understand the potential wide-ranging impact of perinatal depression. So the overarching aim of this study is to examine the long-term outcomes associated with perinatal depression across the domains of mental health, physical health, fertility, and socioeconomic outcomes. So more specifically, our study aimed to address the following 3 questions up there. Do mothers with perinatal depression have worse outcomes than mothers who don't experience perinatal depression? How do outcomes for perinatal depression compare to those who experience depression during a similar life stage, but not related to the pregnancy and childbirth? And then do pregnancy and childbirth influence outcomes independently of depression? So is it specific to that time, that specific event, rather than perinatal depression itself? So our data source was using data from the integrated data infrastructure. Most of you will be familiar with that, but for those of you that aren't, it's a large research database containing linked administrative and national survey data, primarily from government agencies. So it's great for kind of looking at the range of outcomes that we're interested in. So our method was a bit technical, so I'll walk you through it. We started with a cohort of women aged 18 to 40 in July, the 1st of July 2006, about 670,000 plus women. We followed these women for 15 years and categorized them based on whether or not they had given birth in that 15-year window. This was based on whether they were listed as a parent or on a DIA birth registration. Then to assess depression for those who had given birth, we defined their observation window starting from their estimated date of conception. So that was essentially approximately 9 months prior to when they'd given birth, until 12 months postpartum to identify essentially perinatal depression. For women who had not given birth, we matched them to the birth group on observation time, assigning them a comparable start date based on the distribution of conception dates in the birth group. Then for each group, we looked at whether they experienced a depression event essentially during a 21-month window. So this covers pregnancy plus 12 months postpartum for the birth group, and then an equivalent window for the non-birth group. So what this design does is it allows us to compare depression during the perinatal period to depression occurring in a similar life stage for women who did not give birth, while ensuring that the follow-up time across the groups was comparable. And then depression diagnosis during these windows were based on a hospitalization for depression or an antidepressant dispensing during that time. Now, these are the planned outcomes that we want to look at. So I will say first off that it is what I'll present here is preliminary, and this is planned analyses. I will present preliminary results focusing on mental health, the mental health outcomes, but then we do have plans to look at these other specific outcomes as well, and we'll have Lisa joining us very soon on this project to help with progressing that along. Great. So for subsequent mental health events, or after that observation window, after that perinatal period or comparable period, these included later depression, a non-depression related mood disorder, anxiety disorder, substance use disorder, and psychosis, all based on hospitalizations or appropriate pharmaceuticals. We also looked at self-harm through hospitalizations, and we do plan on looking at suicide from mortality records. Physical health outcomes included hospitalized infection and a hospitalization for non-cancerous pain. Fertility and family structure include subsequent parity based on the linkage of the maternal ID to birth registration records. So how many kind of subsequent children is that mother, that particular woman having? And then divorce or dissolution for those who are in a marriage or civil union at the time of birth. That is also from the DIA records as well. So that's getting at family structure. And then socioeconomic outcomes include receipt of a job seeker benefit through MSD benefit records, and then total income using the code module. So this will compile income information across a range of sources, including IR tax, benefit payments, and ACC payments. So I will, of course, just talk about mental health events, as I said. And then our planned analyses, just very quickly, for any stats nerds here, binary outcomes will be looked at with a Poisson regression, count outcomes will be looked at with a negative binomial regression, and the continuous outcomes will be looked at with an ordinary least squares regression. For analyses that will be comparing women who gave birth, so comparing the perinatal depression group to the women who've given birth but didn't experience it, we'll adjust for birth factors, so gestational age, birth weight, the mother's age at birth, and whether or not it was a multiple birth. We'll adjust for demographic factors, including education level, mother's ethnicity, whether or not they were born in New Zealand, marital status and residential location, and then also prior mental or physical health diagnosis as well, related to the outcomes of interest. And for a subgroup of women, namely those born from 1970 onwards, we can link siblings. So what this will let us do is something known as a sibling difference analysis. So we can compare sisters, both who'd given birth, where one experienced perinatal depression and one didn't. And then this will help us adjust for some shared family factors like shared genetics and an early environment as well. So in terms of the specific comparisons, firstly, the first question, do mothers with perinatal depression have worse outcomes than mothers without? This will involve comparing women who'd given birth, one group who'd experienced perinatal depression compared to the group that did not. And then how do outcomes for perinatal depression compare to non-perinatal depression? This will involve comparing women who experience perinatal depression to those who experience depression not related to pregnancy and childbirth in a comparable time in their life. And then finally, do pregnancy and childbirth influence outcomes independently of depression? So this is comparing the women who did not experience any depression, did not have a depression diagnosis. So the group that gave birth and the group that did not give birth. So is it that specific time or event? And so to enable these analyses, 4 groups were defined in our cohort. Those who had given birth and experienced perinatal depression, about 5% of our cohort. Those who'd given birth did not experience perinatal depression, about 36%. Those who had not given birth but experienced depression, about 9%. And then those who had not given birth and did not experience depression, which was about half of the cohort. Now, 40.6% of the cohort had given birth between July 2006 and June 2021, so that 15-year window. In the birth group, those who had given birth, 11.6% had experienced perinatal depression, and 44% of these individuals had their first event during pregnancy, with the rest postpartum. In the non-birth group, 15.1% had a depression event. With that, what we found is age distribution across those with depression and those who did not experience depression in both birth and non-birth groups. Though not surprisingly, there were fewer women over 40 in the birth group. Across both then next up is ethnicity. So across both the birth and non-birth group, we have a greater percentage of European women experiencing depression, which is interesting. We'll get more into that later. And then more next up is New Zealand-born status. So more New Zealand-born individuals experience depression across both birth and non-birth groups. And next, with looking at the mother's education level, more individuals with no qualification experience depression across both birth and non-birth groups. And then finally, looking at area level deprivation, we see a similar distribution and deprivation across all the groups. So just to reiterate, these are preliminary results. These are essentially only adjusting for mother's birth year at the moment. But what we do find, so for the first question, do mothers with perinatal depression have worse mental health outcomes than mothers without perinatal depression? We see an increased risk of all mental health outcomes except anxiety for mothers who experience perinatal depression relative to mothers who did not. Now, one possible explanation for our anxiety findings is the way that we've defined perinatal depression. Because we used antidepressant dispensings as part of our identification, and antidepressants can also be used to treat anxiety, the reduced risk we observe might not reflect a true reduction in anxiety itself. Instead, it could reflect that the women are just less likely to be prescribed an anxiolytic, which is one of the ways anxiety was defined in our data. And then for looking at how do mental health outcomes compare for perinatal depression compared to those who experience depression, non-perinatal depression, we see a very small increased risk for the perinatal depression group for subsequent depression diagnosis. We see no difference for other mood, and then we see a reduced risk of all other mental health outcomes for those who experience perinatal depression compared to those who experienced non-perinatal depression. And then finally, do pregnancy and childbirth influence mental health outcomes independently of depression? So giving birth seemed to increase the risk of later anxiety and depression diagnoses. but reduced risk of experiencing psychosis, but we see no other significant differences. So key takeaways were mothers with perinatal depression generally had worse mental health outcomes than mothers without. However, compared to those with non-perinatal depression, their risk was lower for most mental health outcomes. And giving birth itself increased the risk of later anxiety and depression, but was linked to a reduced risk of psychosis. Now, again, just to re-emphasize, these were preliminary analyses, only adjusting for birth year. So this may change once covariates are included. And it's also really important to state that this is based on service use data and may not reflect the actual symptoms experienced. So what this plot up here is showing is from the Growing Up in New Zealand study. It's showing the prevalence of antidepressant use in pregnancy. So that those are the black bars, and then the white bars are those who essentially were above a threshold for high depressive symptoms. And so what you see is differences between medication use, right, the prevalence of that and the prevalence of high depressive symptoms, indicating a level of unmet need. And then in particular, when you look at some of the gaps, younger mothers, those from more deprived areas, and as well as those of non-European ethnicity, are showing more unmet need, right? So much greater prevalence of high depressive symptoms relative to treatment from antidepressants. In the cohort from this study, we do see a greater percentage of Europeans amongst those experiencing depression than not, and vice versa for Maori, Pacific, and Asian women in particular. But it's important to keep in mind that this may not reflect need within these communities, just who's actually getting treatment. And the study itself, of course, won't be able to, what it's capturing is long-term impacts of receiving a diagnosis during the perinatal period, essentially, and not necessarily impacts of the depressive symptoms themselves. So just quickly to end, before I move on to questions, I want to thank my collaborators. So we have a team, this is our international team across the US, as well as that have access to the Norwegian data as well. And then, of course, Barry and Lisa, who will be working with the New Zealand data. Perinatal anxiety and depression Aotearoa have been fantastic partners to work with. Statistics New Zealand, of course, for access to the data, and the Public Policy Institute at the University of Auckland for their data lab to do this work. Yes.
And did you do, as part of this larger project, was there any qualitative research done? Which I ask because I wonder how many people who upon, I don't want to say being diagnosed as being pregnant, but who upon becoming pregnant stop medication usage or don't take antidepressants because of being pregnant.
Yes, not with this particular project, but we there have been other studies done that have looked at essentially the distribution of antidepressants from sort of before pregnancy, during pregnancy, after pregnancy, and you do see it. Yes, so yeah, we will. I guess there will be some women that may experience symptoms and just go off medication, but they may pick that back up postpartum. I'm not sure. What we are considering doing as well is to sort of reduce that to kind of make sure it's specific to pregnancy again and not sort of a continuation potentially, is another analysis where we will do sort of a washout for those that have prior depression as well. Yeah. Just go.
Yeah, thank you. Kind of going a little bit related to that is, do you know how many people who are taking antidepressants? So the big question is, how many of your depressed example are because they take the antidepressants, and how many are from the
Hospitalizations?
And of those who are taking antidepressants, do you know how many are taking them because of other reasons? Because often people are prescribed that, but not.
Yes. Very good question. The majority of them are taking it, identified through pharmaceuticals, over 90%. And it is, I guess, an issue in that they will be taking it not necessarily for depression, and as I said, potentially for anxiety as well. We may not be able to kind of do the analyses broken down. It will depend on numbers, but we would like to also look at it, do another sensitivity analysis with just the hospitalized group as well, to see what we can find. But again, dependent on what the numbers are for that. Yeah, it's a good point. Yes, and then I'll move on to the.
Are you able to isolate out the difference between what they call clinical depression through the pregnancy or post, or social and environmental causes of depression afterwards?
Not with the administrative data. So I guess you're meaning like something that could be sort of a biological experiencing distress.
The environmental, situation that the people are in.
Yeah.
Or the just purely what they call social depression because of other extraneous factors.
Yes. This will just be essentially who's being treated for it. So we wouldn't be able to, I guess, separate or identify what the cause of what's contributing to the treatment. Unfortunately, not with the sort of data, essentially with the administrative records, but this is where something like, the kind of birth cohort studies that ask these questions of mothers would be really valuable in understanding further, or qualitative research to sort of understand further.
Some more potential qualitative.
Yes. Yeah, definitely. Voice type.
You might have actually had it in a slide before, but the other mental health outcomes, are they also based off of pharmaceuticals?
Most of them, well, a combination of hospitalizations, so clinical diagnosis codes, and then specific pharmaceuticals for those types of diagnoses. Yes.
Are you able to? Is there any literature to support for those types of pharmaceuticals for the different mental health outcomes that you've listed, the prevalence of off-label use or prescription? So you can kind of, give that kind of caveat or limitation.
I don't know how we look at that, because we don't know why they're being prescribed. We just know that they're being dispensed a medication. So yeah, do you have a thought?
You might be able to look at some antidepressants will be more likely to be prescribed for things like pain. So you might be able to do sensitivity.
Right.
But you'd still have the issue.
Yeah.
I was just thinking about the opportunity, given you've done all this thinking about the way the cohort is framed, if you were to look at other parents.
That was my question too.
I think it'd be really interesting because, one of the opportunities, it'd be so hard to do that kind of research without the IDR, but using the IDR, you're looking at, you would probably be capturing already when there's two mothers and a child, for example, in your cohort, so you're not necessarily sure which one's the birth mother, isolating out those physical effects if there are some. But we also know that there's...
Yes, so we will get it will be birthing mothers specifically in our cohort.
Oh, okay.
Yeah, because it's linked... Actually, no, you're right, because it's parent one.
And you said it was named on the certificate, so you could have...
Yeah. We go on parent one, which I guess is making the assumption it's a birthing mother, right? But yes, you're right in that we can also look at the impact of a partner, and I think that would be, great. That's not something I think that's looked at as well.
Yeah, you see there's cohort studies of same-sex male parents, and one of them will have the same kind of amygdala response, and the brain chemistry is, just to give the comment before around separating out those differences. It'd be quite interesting to see. Quite a small cohort, but it's quite an interesting study.
I think in general we find that men tend to experience postnatal depression more than antenatal depression. But that was my thought, is that we should be doing this for paternal
as well. Yeah.
Done that work.
Yes,
growing up work.
We have, I think it would be a really valuable part of it as well. I think some of this is just kind of getting the methods down within the mums first before, but I think it is, I agree, it would be really valuable.
I'd love it if you could also, if this is completely possible, to add on the grandparents who are then the primary caregivers of the children as well. That would be amazing, but very hard to identify them.
Yeah. I don't know how good the linkage is. I don't think it's particularly good for grandparents.